weekly session of Virtual Global Spine Congress conference. We have the honor and pleasure of having a friend of mine today. This Dr. Alex Thomas. He's a neurosurgeon from Wilmington, North Carolina. He's one of the first early adopters and probably one of the inventors of the single position surgery. That it's a pretty hot topic today in the world. So we are pleased to have you, Alex. Welcome. Feel free to go with your presentation. I will be mute, but in here, right?
Awesome, Alfredo. Well, welcome everybody. I really appreciate the invitation. This has been an honor. It's an honor to be invited. I had the fortune of spending a lot of time this summer with Alfredo and Ali and then others at multiple AO courses in Latin America, and it has been a very rewarding experience for me. So I'm honored to be here tonight. So I'll go ahead and share. Hold on a second. Let me share my screen here. I am sharing it. Can you guys see the slides?
We're good. Yeah,
Good.
perfect.
All right. Cool. All right. So I'm going to talk about my experience so far with single position surgery and lateral single position surgery. For those who don't know, I live in Wilmington, North Carolina. That is in the southeastern part of the United States on the coast. It's a wonderful place to live. I encourage you guys to come visit. Here are my disclosures. Some of them are partially relevant in this talk. And so here's the outline for the talk. We're going to talk about why did lateral single position surgery arise? What are what I call the three pillars of lateral single position surgery? What are some of the benefits of adopting single position surgery and lateral in general? In particular, how does single position surgery in the lateral position differ from that in the prone? A lot of people are talking about both of these modalities at the meetings, and we'll talk about some of the differences in between the two. And then if I have time, I'll close with a quick case example. And so Alfredo and I talk about this all the time. He does much more sophisticated surgery than I do. I am a degenerative surgeon. I do 1, 2, 3, 4 level fusions in the lumbar spine, and I truly believe that the XLIF, the lateral lumbar interbody fusion, and I apologize. Sometimes I use those terms interchangeably just out of habit. I don't mean to endorse XLIF as superior to any other form of lateral surgery, but I think that the XLIF is the best way to do a lumbar fusion. There is no question that if I had a spondylolisthesis, like this case here in my own spine, I would want an experienced XLIF surgeon to do it. I would want an XLIF without a doubt. I certainly would not want a posterior fusion. And I think that what we've shown is that if, now that we have 20 years of experience of XLIF, if you do it the same way every time, you stick to strict procedure, steps of the procedure, you are considered about retractor time, you can have excellent results. There's this old notion that lateral surgery is not safe at L4-5. We recently published this at the beginning of this year, the largest study to date looking at XLIF at L4-5. And while there was a 0.8% rate of femoral neuropraxia initially, none of those persisted at 1 year. And very, very low rate of thigh pain and dysesthesias as well. And if you compare that to for example, MIS TLIF and Paul Park's large series, we feel it's actually safer than TLIF. So when done correctly, I think it is the best, safest way to do a lumbar fusion. Unfortunately, not everybody feels that way, particularly in the United States. This is data from the United States. This is market share for the device manufacturers of the different types of fusions. And you see ALIF, you see PLIF, TLIF, and lateral. And you have past data all the way up to current data, and then we see projections out to 2029. And if you look at this, this is, look at last year's data, for example. Last year there was complete data. There's lateral surgery makes up only a third of the surgery that's being done in the United States. I think it should be almost 100%, but still only a third of the fusions are done this way. Posterior surgery is still the most common way. And so the question is, why is that? And there are limitations. The truth is there's still perceived limitations of lateral surgery. I think there's three main limitations. Um, the first one is, what do you do about screws? If you want to place posterior instrumentation, most people feel like you have to flip prone to place screws, because that's how we were all taught to place screws. What if you want to do a direct decompression? I have tried to do a direct decompression in the lateral position. It's very difficult. It's certainly easier to do in prone. Um, and then the biggest one, what do you do about L5S1? Up until recently, we haven't been able to solve that major crux. Excellent procedure for L4-5 and above. Unfortunately, just about everybody with degenerative disease has problems, not just at L4-5, but also at L5S1. So those are the limitations that we, over the past several years, have set out to conquer. The first one that we addressed was, what do you do about the screws? And so in late 2013, I got tired of getting, taking the time to break down the drapes, flip the patient. We got pretty good at it, but I just got tired of wasting that time. So I said to my team, let's just try to put the screws in with the patient on their side. And literally since that day, we have never looked back. We published our first experience with this technique. This is using only fluoroscopy. And sorry, that's kind of loud, but first 300 screws in about 70 patients. And we showed that it was very safe and very reproducible. And now fast forward 10 years later, we look at multi-center data, over 2,100 screws in about 450 patients, and only 6 patients have required reoperation for malpositioned screws. That's 1.3% rate. And if you compare that to the rates for prone screws in the literature, it's right on par with those. So even with just fluoroscopy, this is a very safe and reproducible technique. And by the way, this is a technique done with fluoroscopy only in the lateral view. Alfredo and I hopefully will be writing this technique up soon with an operative video that will show step by step how we do this, so that everybody can adopt this. Since then, for really just because I was worried about the radiation exposure, we've adopted other technologies. You certainly can use robotics for this. This is my partner here on the left side of the screen. He's using the Mazor robot to place screws in the lateral position. These days, I use a 3D navigated platform called Pulse, where I think it's very effective, and again, minimal radiation to the surgeon. We've placed, this is a little bit older data now, we've placed over 1,000 screws, and we've, knocking on wood, we've yet to have a revision of a screw yet. The other benefit is, and I'll get to this later, look, that's my access surgeon working on the front while I'm working on the back. So when you start to adopt this concept of simultaneous work, then you really see your efficiency skyrocket, and we'll talk more about that in a little bit. If I can advance this here. Okay, so what about the L5S1 problem? We talked about the screws. What about L5S1? So we all have cases like this. This is a very common case that comes in. Unstable spondylolisthesis at L4-5, severe spondylosis at L5S1. This is the case that we see several times a day in our clinic. And so what do you do about this case? And I have plenty of x-rays like this. I'll be the first one to admit, before I had a good solution at L5S1, I have plenty of patients where I did a beautiful surgery at L4-5, and just ignored the problem at L5S1, hoping that that wasn't the pain generator. Some of them did well, some of them did not. I dabbled with TLIF in the lateral position. That's horrible. But if I really needed to do L5S1, I would do multiple positions and do a TLIF at L5S1. And of course, everybody says, we give these talks at these meetings, and everybody comes up to me and says, oh, well, Alex, I've been doing single position surgery for a long time. It's called a TLIF or a PLIF. And, they think they're really cool and smart when they say that. But look, I mean, everybody knows this. Anybody who does lateral and anterior surgery knows that it's the size of the spacer that matters. And you just cannot, if you compare to the anteriorly or laterally placed spacers, you simply cannot place a large spacer. And so if you really care about doing a true robust 360 fusion, you do this. You do a supine ALIF, you close the patient, you reposition to the side, you do an XLIF at L4-5, close the patient, reposition, and then you do your screws from L4 to S1 in the prone position. That's a 6-hour process, at least it used to be in my hospital. And so, to be fair, for full credit, what got me thinking about the L5S1 problem in the lateral position was going to visit this guy. This is Rick Hines. This is from the Spine Summit earlier this year. We gave a talk together. He is the father of OLIF, the oblique approach to L5S1, and he was doing this before anybody, and I think was probably the godfather of thinking about how do we address L5S1 and the lateral position. So full credit goes to Rick. And so out of that visit and out of my experience with lateral surgery comes this. So this is a retractor-based solution for L5S1, where with the patient on their side, you can do a true midline ALIF. This is not an oblique approach. You come lateral to the rectus and come right down to the front of the spine at the midline. It's the exact same thing with the patient turned on their side. And so the question number one is it safe? If you turn the patient on their side, is it safe? And so this is initial data that we published back in 2022 with some of the original members of the lateral single position surgery study group that I worked with, comparing a single position cohort of 124 patients. These are propensity matched cohorts, a single position group versus a traditional group where you did an ALIF and then flipped for posterior hardware. And the first thing you see is we don't see ilius anymore. Okay. There's something about keeping the patient on their side and gravity doing all that retraction for you that with single position surgery and lateral ALIF, we no longer see ilius. The other thing you see, and I know it's a lot, but other than that, there's no difference in complication rates, no difference in bowel injury, no difference in vascular injury, retrograde ejaculation. It's the same procedure with the exception of ilius. But look at this though. Look at the difference in the operative time. It takes twice as long when you change patient position. And that translates into increased length of stay, increased blood loss, and of course, increased the radiation exposure was nil. And so not only do we think it's safe, we actually think because of the ilius, it's safer than traditional supine ALIF. What about sagittal alignment? A lot of people would say, well, look, you can't get the same sagittal alignment with the patient on their side. We looked at this question as well. This is almost 500 patients that we wrote up in late 2022 with Kaveh Kajabi, Cristiano Menezes, and Brett Browley. Again, comparing a lateral ALIF cohort with a traditional supine ALIF with PERC screws. And look, there was no difference in segmental lordosis, no difference in overall lumbar lordosis, and no difference in disc height or slip correction. It didn't matter. It doesn't matter what position the patient's in when you put the spacer. It's really the spacer that does all the work. And there's tons of other literature showing that. And so when you tie it all together, this is what you have. These are the three pillars. You have PERC screws in the lateral position, ALIF in the lateral position. It's all built around lateral lumbar interbody fusion, built around it and solving the limitations of lateral fusion. That's what lateral single position surgery is. Okay, I didn't talk about direct decompression. Definitely, if you are a surgeon that feels that direct decompression is necessary in a case, it's certainly going to be easier in the prone position. I cannot argue that point. The question is, do you really need direct decompression in most cases? And I would argue that the answer to that question is no. This is my data that I looked at last year. This is I wanted to see the failure rate of indirect decompression after XLIF. Almost 600 patients, 750 levels ish. Only 7 of those patients required reoperation for failure of indirect decompression. And if you take out the cases, the patients where I messed up the case, I didn't execute properly. So I didn't correct the spondy or I damaged the end plate during the surgery. That rate drops to 0.7%. That's less than 1% rate of failure of indirect decompression in XLIF. And we validated that in another study as well, looking at ALIF in multiple level cases. Only 1.7% failed. So I think the number is somewhere in between these two. And so if you look at my rate of durotomy, for example, for Metrix laminectomy, it's about 5%, maybe 3 to 5%. And so these days now, I never consider direct decompression right off the bat. It is always indirect decompression. Now, if it's cauda, equina, or something dramatic like that, sure, you're kind of forced to do it. But in the vast majority of cases, I don't even consider direct decompression. And I counsel the patient. I say, look, here's what indirect decompression is. It works 99% of the time, meaning there's a 1 to 2% chance in a couple of months I have to bring you back for an outpatient procedure. But here's my risk of tearing your dura or injuring your nerve root with the drill when I'm drilling around it. And you tell that to the patient and they say, oh yeah, I want to try the indirect decompression. They're totally bought in. And so I think, yes, you occasionally have to do a direct decompression, but I think the rate of failure is exceptionally low. And we will routinely do cases of schizo grade C, D, facet cyst, free fragments. We do it all the time, and it works as long as you don't mess up the end plates. And so, again, this is how you tie it all together, the 3 pillars. Patient on their side, heads up here, legs are down here, right side up. I'm using a navigation system. In this case, it's a 2D system called TrackX to place screws in the back. My access surgeon is working here. No need for direct decompression. And we will routinely do an L4 to S1 case like this in about 70 to 80 minutes. Tell me there is a better way to do a fusion from L4 to S1 than this. How can you do that by placing huge spacers anteriorly, percutaneous pedicle screws without changing the position in an hour and a half? You can't even the most facile MIS TLIF surgeons, which by the way I think is an inferior procedure, can't do it that quickly. And eventually the whole team buys in. If I try to flip a patient now, my team has a mutiny. Even the anesthesia service is bought in, and they will take the breathing tube out with the patient on their side while we're still getting the wound dressed. Everybody buys in to this notion of maximum efficiency. And it matters. I remember presenting this at a meeting, I think it was the old Solus meeting several years ago in a room of all the lateral surgeons in the US. And this was probably 6-7 years ago we presented this. This was when we were first starting to think about single position surgery. And the reception was awful. People thought this was going to be dangerous. And I remember, and I've talked to Pedro Borjano about this since then. Pedro Borjano, when I told him that speed is important, he was very upset by that notion. And he said that was just an opinion. I know he's since come around and he's a huge believer in lateral single position surgery. But this is initially people just thought, well, Thomas, he just wants to do more cases. He wants to, go home, play golf, whatever, all this nonsense. But that's not what it's about. Doing these cases more efficiently is not about me going home early or doing more cases so I can make more money. That's not what this is about. Clearly, simply put, the faster you get the patients out from under anesthesia, the better they do. That is clearly demonstrated in the literature. This is a paper that was just published a few months ago out of Utah, where they looked at almost 80,000 patients from the NSQIP database. And look, every hour that the patient spends under anesthesia, the complication rate goes up linearly. It's clear. And that's for all age groups. And there seems to be something that happens at the 4-hour point where it really starts to go up much more rapidly. And this has been borne out in so many other of these large database studies. The longer the patient's under anesthesia, the higher the chance that they have a complication. They have a complication, and it makes sense. And we see that all the time. When you do an L4 to S1 fusion in an hour and a half, you get the patients up walking that afternoon, they look incredible. There's something about the power of that anterior reconstruction done in such an efficient way. You cannot tell me it's not lateral single position surgery. These patients almost always go home the next day, and they do so much better than the traditional kind of posterior fusion. So what about this? That brings me to this. This is another form of single position surgery. This is a prone lateral surgery, first described again by Pedro Borjano and Claudia Lamartina, and popularized by Luis Pimenta as an alternative to trans-psoas surgery in the lateral position. I definitely tried it when people started doing it. I tried it for several cases for extensions or revision. You can see my assistant there removing old hardware, and I think for situations like that, it's beneficial. And so here are some of the purported benefits of prone lateral surgery, and I think it was talked about a bit more a couple of years ago. I think people still talk about it. I feel like it's a little bit less these days, but here's some of the benefits. I mean, clearly the prone position is more familiar for placing screws. However, I think with just a little bit of commitment to learning, any one of you can learn how to place screws with the patient on their side. It's really quite straightforward, and hopefully the video that Alfredo and I get out here soon is going to help you with that. They say it's easier to revise or extend hardware. Okay, so I think that's certainly partially true. What I do these days, I used to do prone lateral surgery just for this purpose, for extending hardware. And I had a couple cases where even in smaller patients, I couldn't feel the psoas when I was dilating, and I kind of got so kind of frightened by that notion of not being able to feel the psoas muscle, even in a smaller patient, that I abandoned prone surgery. And so these days, what I do is I will use the navigation system. I will sit down on a stool. I'll have a headlight, and I'll just raise the patient all the way up to eye level in the lateral position, and I take the screws out with the patient on their side. I just did that today. I do that routinely now. It takes me about 15 minutes to get old hardware out these days. It's still not fun. It's never fun to take out old screws, but that's the way we do it now. And the patient's already on their side. We're ready to go. So that's certainly not a deal breaker that mandates the prone position. Another topic, easier for posterior osteotomies. I can't argue with that one. If you need to do shortening of the posterior column, address a fixed deformity or iatrogenic flat back, there's no question that the prone position is superior. And I think that is an excellent application for prone lateral surgery. Easier for direct decompression. Yes, that's true. If you need to do a laminectomy, the prone position is easier. But again, 99% of the cases do not require a direct decompression. And again, I understand that's controversial. It's a leap of faith to get to that point where you believe that. But if you commit to a few of these cases, you'll know what I know. Better segmental lordosis correction. That's another one that is true. I think the data is pretty clear that you can get better segmental correction at one level with the patient in the prone position, because flipping the patient prone allows you to get a little bit more curvature in the lumbar spine. The question is, does that really matter? We know from some of Juan Uribe's data and others' data that if you aggressively correct segmental lordosis at one level, the other levels will accommodate for that increased segmental correction. And so does it really affect, is the prone position really better for global lumbar lordosis? I think that can certainly be debated. There's plenty of literature that shows that the position doesn't matter when it comes to global lordosis. And I think that this is an important one. And Rick Hines taught me this point. I think if nothing else, I think if the concept of prone lateral surgery is getting surgeons to move away from PLIF and TLIF to do anterior surgery, then I'm all for it. It's just like I wouldn't argue if someone wanted to do an oblique approach or anterior to psoas approach. As long as we're all doing anterior surgery, I think the patients are winning. There's also some unique anatomical considerations that I think people should be aware of if you are going to start doing prone surgery. And I encourage people to look at some of the changes that happen not only at the level of the psoas muscle and the plexus, but also the visceral contents when the patient's in prone versus lateral position. This is a study that we published with Cristiano earlier this year. We put 34 patients on a prone surgical positioner like you would use in a true prone lateral and did an MRI with them on that positioner. And then we did the MRI with them on their side. And every one of the patients, when the patient was on their belly, when they were prone, the left colon was pulled back into the approach corridor in every one of the volunteers versus lateral. This is just a representative set of images. And what we think is happening is, as you know, the colon is tethered in the retroperitoneal space. And so the argument for some of the prone advocates is that, well, prone's safer because it pulls the psoas muscle and the plexus posteriorly because of the hip extension. But my argument is, and I think it's Cristiano's argument as well, is that you can't pull one retroperitoneal structure back and not the other. And so the colon gets pulled back as well. That does not mean it can't be done safely, but I think there's some of these challenges that you should be aware of if you're doing this sort of surgery. But here's the biggest thing. Prone doesn't address all the limitations of lateral. It only addresses two of them. It doesn't address what, in my opinion, is the most important one. What do you do about L5S1? You're still left without a solution there unless you are a purist, like my friend Ash Patel in Chicago, who's a big prone surgeon. He'll do supine ALIF, flip prone, and then do the prone XLIF and screws in the prone position. And so he's a purist. He'll do it the right way. But a lot of people just say, just do a TLIF at L5S1. And yeah, I used to do that too. This is not David Okonkwo's films. I was just teasing there, but this is one of my patients where we were planning to do an L4 to S1 fusion, and we could not mobilize L4 to S1 lateral single position surgery, so a lateral ALIF at 5-1, but we couldn't mobilize the vessels, and so I had to abort that. I already had the screws in, and everything was done by the time the access surgeon told me he couldn't get to 5-1. And so we closed up. I brought him back a day later, 2 days later. I removed the rods on one side and I did a TLIF at L5S1. And admittedly, I'm not the best TLIF surgeon in the world, but these are the results that I used to get. I mean, look at this, look at the size of this spacer and look at the subsidence there. And trust me, this cage was placed perfectly. This banana cage was placed perfectly right off the bat, but he got subsidence like so many of these spacers do. And so, this is the equivalent. You do this beautiful reconstruction from L4-5 and above with these huge spacers, and then you put this little tiny spacer in at the base of the construct. That always just seemed kind of silly to me. And so this is just my sentiment. I won't be too vocal about that in front of this crowd. And so I do think that prone has a position, a role prone lateral. Again, it's increasing adoption of anterior surgery. This is something that we published in the European Spine Journal supplement on single position surgery a couple of years ago. There's an algorithm here that kind of suggests when you could use prone versus lateral single position surgery, and it really does hinge on this L5S1 level. If L5S1 doesn't need to be addressed, I think prone's an excellent option, but otherwise, you may want to consider the lateral position. And so this is a typical case that we'll do. I love doing these corrections. Um, this is a 60-year-old guy, retired Marine Special Forces soldier. So those guys do a lot of jumps out of airplanes and really crazy things with heavy loads on their back. Severe axial back pain, multi-level spondylosis, and loss of lumbar lordosis. And so for this gentleman, of course, he failed all the conservative management. He's not terribly malaligned, but there's certainly PIL mismatch and some compensation in terms of elevated pelvic tilt. And this is a case that we routinely do in the single position now. We have this workflow dialed. So the way the workflow goes is the patient's positioned on their side. I'll start with the X lifts. I'll start from the top down because usually the top one's the harder level for me to get to. We'll do 2, 3, 3, 4, 4, 5 X lift. We'll put a pin in the iliac crest. We'll spin with the image acquisition system, and then I'll call the access surgeon in. And then while he's working on the front access, I'll be placing the screws in from L2 to S1. And then again, usually by the time he's down to the front of the spine, I'll have the screws in. Then I'll come do the A-lift and then come back around and use Bendini to custom contour a rod. And routinely do these cases in about 2.5 to 3 hours. And we're starting to get to the point where they go home in 2 days. And if you think about that, I used to stage these cases. I used to do these cases over 2 days. I would do the spacers on one day, on a Tuesday, and then bring the patient back on a Thursday to do the screws and the rods, because that was what I felt was the only way I could do it. And that was before single position surgery. So if you think about it, you're doing a true 360 fusion, front and back of the spine with huge spacers in 3 hours. There's no other way. There's no other way that you can do that. And so that's the power of lateral single position surgery. The lateral position is the only position in which you can do a fusion from L1 to S1, front and back, without changing the position of the patient. And so in conclusion, like I said, lateral single position surgery really came about to address these cruxes of lateral lumbar interbody fusion. Those were, what do you do about L5S1? What about direct decompression? What do you do about screws to place the posterior hardware? We talked about the 3 pillars of lateral single position surgery. That's what I call them. Screws in the lateral position, A-lift in the lateral position, all built around X-lift and solving the limitations of X-lift. Multiple studies have shown that it's safe, it's reproducible. If you commit to it, you will see massive improvements in your OR efficiency. I think if you're already doing lateral surgery, the first step for you would be, all right, I'm going to commit to learning how to do screws in the lateral position. If you have navigation, great, use it. It'll probably make it easier for you, but you certainly do not need navigation to do it safely. And we showed that. Prone single position surgery certainly has utility as long as the case involves L4-5 and above. When you start involving L5S1, there are some limitations there because only lateral single position surgery allows you to do a true 360 fusion from L1 to S1 in one position. So that's all I have. I'm certainly happy to take questions, and we'll open up the floor.
Awesome, Alex. That was a great review and overview of this exciting technique. We don't have a question from the chat yet, so I will jump with a couple of questions I have. You mentioned that 98, 99% of the times you have a pretty good indirect decompressions. In which cases you decide to go for a direct decompression? You said Cauda what else?
I think at that point, I think that's it. I think that's it. And
Awesome.
so, and I understand that that is very controversial, and it took me a while to get here. And admittedly, probably probably I got to this point because I started getting lazy about flipping because we got so efficient with single position surgery. I was like, do we really have to flip and do the laminectomy? Let's just try it. And sometimes the rep or my physician assistant, they'd look at the films and they'd say, that's pretty much an occluded spinal canal. Are you sure you want to do that? And it works. I think it has just as much to do with stopping the motion of, for example, at a spondy. Um, I know there's some data that shows, bony lateral recess stenosis and things like that may lead to higher risk of failure. We're about to start a true prospective long-term study, a multi-center study looking at this to see, okay, if we look at this in a prospective fashion, where every surgeon on the study has to commit. Like you can't say, well, yeah, I'm going to do it for this, but for this free fragment, I'm still going to take the fragment out. No, you got to commit. That's the prerequisite for joining the study. That's going to really show us, I think, what the true rate is. This is what I'm excited to finally prove once and for all, because a lot of the studies are kind of retrospective, multivariate analysis, kind of trying to find trends. Nobody's really looked at this in a prospective fashion in a multi-center study. So we're submitting that to the IRB this week. And so stay tuned on that. That's really what I want to, and I'm certain that I think what's going to be just as important is your technique. If you violate the end plates, case is over. Indirect decompression is not going to work. But if you execute correctly, it works almost every time.
Yeah, maybe getting some decompression, it's enough for most of the patients. You don't need to
Yeah,
get to Scheisser's A, maybe go to Scheisser's D from a B. It's pretty enough for a patient that the symptoms gone. So that
and there's sorry, I'll
yeah,
say one more thing. Sorry, Alfredo. And I would encourage people to look up this data. This is really cool data. I think it's Japanese data where they've looked at these patients, SCISA grade C or D. They did anterior fusions on them, no direct decompression, and they followed them. And they did MRIs, I think, in 2 years, and the ligament goes away. The ligament of flavum shrinks. And so there's something that's happening biomechanically in the ligament when you stop the movement that causes it to involute. And so to me, that's fascinating. So people always think, well, you just take away the buckling, and I think that that's part of it, but it also gets smaller. And that's not just me making that up. That's been shown in some of this Asian literature. I encourage people to look that up.
yeah, stability matters. So when you have synovial cyst or extruder disc herniation, or you go for a direct decompression, or still go with indirect
I
decompression.
still, I still, I still, I
So
still.
indirect decompression, right?
And I know it's controversial. I know people, it
No,
takes
no,
a
I don't know.
tremendous amount of faith, but it
Faith
works.
and
And by the
cases.
way, and by the way, and by the way, resist the urge if you're doing lateral or anterior surgery. Resist the urge to say, "Look, I've got this facet cyst back there. I want to do what Thomas said. I want to get that indirect decompression. I'm going to put a big spacer in because I really want to stretch it out." Don't do that. Use small spacers just like you would for any case, because if you try to over distract and use those big spacers, you know what's going to happen. You're going to damage the end plate, and then the case is over. And then you're going to remember this talk and be mad at me because you'll say you'll think it didn't work. So just resist that temptation to oversize
Yeah.
your cages for
What?
indirect.
Awesome. What is the average size of cages you typically
10,
use?
yeah, 10, 8 or
10.
10,
Yeah.
8 or 10. As a matter of fact, in my OR, this is for lateral cages. In my OR, if I ever say 12, there's a rule. They have to question me. They have to say, "Wait a minute, you said you're never allowed to put 12s in. Why are you doing 12s here?" So it's just
That's good.
exceptionally rare.
And for what is the setup, like a step by step, for when you do a lateral? You do like a implant elevator or a box cutter. What are the instruments you use to protect the end plates?
That's a good question. So I think you can have some variation in these techniques when you're working in the disk space. I just encourage people to find the 4 or 5 instruments that work best in their hands, do that efficiently, but don't waste a lot of time. What I do is after I have the retractor placed, I'll do the annulectomy with the knife, and then I'll take the box cutter. I'll go right to the box cutter. If it's a relatively well-preserved disc height, I'll use the 6 mm box cutter, which is the standard one. If not, I'll use the 4 mm. It's very thin, and it's much better at protecting the end plates. You won't violate the end plates. I actually have some good pictures of it flexing and bending on the way through a disc space. It's a little bit more forgiving. So if you are doing lateral surgery and your reps can get you a thin box cutter, it's great. And then just quick ring curettes, rasp, and go. We're careful to do a good discectomy, but again, not wasting a lot of time. The other thing I'll say is a couple other kind of tips for efficiency. I'll measure on my pre-op images what I think the cage will be, and that's almost always right. It's almost always a 10. And then the technician can have the cage loaded with the graft, so I'm not waiting for it. It's ready to go. Boom, put it in. And I don't do a bunch of trialing again because I know the size of the spacer that I need from the pre-op images. Because I think if you're trialing a bunch, that's another way you can damage the end plates if you're not careful.
Good. What is the case you discourage people to do a lateral A-lift? There's some people you prefer to do supine, like pre-obese patients or high pelvic incidence, or
So
it's the same for you.
So that's a good question. I think the caveat there is that before lateral ALIF, I was not a very big ALIF surgeon. I did not do a lot of supine ALIFs because I didn't like the morbidity of it. And so maybe I'm not the best person to ask. Um, I think of them as the same. So it's less of should I do this A-lift case in the lateral or supine position? If it's an A-lift case, it's in the lateral position. I think the fork in the road for me is this a safe anterior case?
Mm-hmm.
Have they had radiation? Have they had a bunch of retroperitoneal surgery? Have they had an infection? Those are the cases where we've had problems mobilizing the vessels. I'm very blessed to work with an outstanding access surgeon. I know you work with an access surgeon, or do your own?
I do myself.
You do yourself, yeah. And so I would love to start doing myself actually, but so I'm very lucky. He can do anything. The case we did yesterday was previous radiation, a couple of surgeries with mesh, all this stuff, and it was like a 10-minute approach. And so we're pretty lucky there. But so I don't know if I'm the best person to answer that question. As far as I know, people have asked me, okay, what if it's a high pelvic incidence case and it's a very steep angle? That case is hard no matter what. It's definitely
Yeah.
hard for MIS TLIF when you're kind of putting your head like this, trying to look down a tube. And so in those cases, we'll do lateral. There's a couple tricks you can do. You can use angled instruments to gain access to the disc space. And another thing is always have your assistant push in the back, and that opens up the disc space. And then if all else fails, I've done this probably 2 or 3 times, stop, go put the screws in because the patient's on their side, you have access to the back. And then you can start manipulating the screws to help get into the disc space just a little bit better. So we haven't found that the high PI cases, I think our max PI was 83. Isn't
Mm-hmm.
the prettiest post-op x-ray. The cage is perfect, but the patient did fine. But I think that case is hard no matter what.
Yeah, I agree. So you talk about the good, the bad, and let's talk about the ugly. There's always the vascular complications are the ugly of this anterior and lateral surgery, right?
Yeah.
How you deal with these vascular complications when you're doing lateral AV?
I will talk about vascular complications. I'll answer that question about both lateral ALIF and XLIF, because unfortunately I have experience with both. So we have now a ton of experience with doing these cases in the lateral position. I can think of certainly half a dozen cases where it was scary. We had vascular injuries that were scary. And that's not, I don't want people on the call to think, oh, that's because they're doing ALIF in the lateral position. Of course they're having these injuries. No, we have a very skewed practice. We will try anterior on everybody, okay? On everybody. Um, Radiation, previous surgery, whatever. And so occasionally we get an injury. And so usually that's from mobilizing the vessels. Usually it's the back wall. And so we have a couple things ready to go during these approaches. We have a long needle driver, like a long Castro needle driver with a 6.0 Pro lane, 5.0, 6.0 Pro lane, ready, loaded up, ready to go if we need it. But with more experience we get, we move away from direct repair because oftentimes that takes time and it can often make the injury worse.
Mm-hmm.
And so now we use two things. We use, we'll take Surgicel, okay, a sheet of Surgicel, and we'll inject a couple layers of Surgifoam or some sort of injectable thrombostatic agent, and we'll roll that up, and we call those tacos. And so we'll have a couple tacos ready to go too. If there's a tear, don't panic. Take a sponge stick, a little bit of direct pressure, take a taco, put it right on the wound. You can even put the blade on top of the taco to hold it there. That fixes just about every injury with time. I think you could really overdo it with trying to repair. And then the last thing, if you're doing anterior or lateral surgery, please get the following in your OR. There's something called Everest, Evarest. There's another product that's similar called Tocacil. These are sheets of fibrin sealant. They have a powder on the active side. They look like almost like Surgicel, but a little bit thicker. This stuff is unbelievable. You can cut a sheet of this and put this down on a vascular injury, on a CSF leak. It is magic. So we use that stuff not infrequently. I still do endonasal skull base surgery sometimes, and I'll recreate the roof of the sphenoid or floor of the skull base with Everest as well. And so it's awesome stuff. The most important thing is, I think most of you know this if you're doing anterior surgery, do not panic, don't overreact. Just put some gentle pressure on the iliac vein. That will control things. And then just stop and think about what you're going to do. Gentle tamponade with some thrombostatic agent fixes it. And the last thing I'll say is, this is something that Vanita Chandra told me at Stanford. She's a vascular surgeon that does a lot of these approaches. If you can, if you're in trouble, rather than spending a lot of time trying to put more stitches and holes in the vein, just call the endovascular surgeons to come help. I think calling them early in the most extreme circumstances is beneficial. I'll tell you about one case that we had in my hospital. This was an OLIF L5S1 case. Wasn't my patient. It was maybe it was a 4-5 case. I can't remember. A different surgeon. Same approach surgeon that I use, and the approach surgeon came back in the space, the cage was in, case was done, and the neurosurgeon said, "Yeah, I saw a little bit of bleeding from that down blade there. I don't know what it was. I didn't touch it." And then left the room. And then my friend, the access surgeon, says he went to pull the bottom blade out, and blood was immediately coming on the floor. It was the worst injury he'd ever seen. And they tried everything to get this patient to stop bleeding, and they couldn't, despite all the things that I just mentioned. Catastrophic posterior wall tear. And so because the patient was on their side, they extended the incision, called another vascular surgeon in, couldn't fix it. Because the patient was on their side, the vascular surgeon got access to the popliteal vein in the knee, at the back of the knee, with a catheter, floated a catheter up, put a stent in, fixed the problem. It was amazing. I should have written it up. It was the coolest story, all because he could access another benefit of having the patient on their side. So don't be afraid to get them involved early. I'll tell you about, I've had 2 or 3 minor to moderate injuries in the iliac veins doing XLIF. I always do my XLIF right side up for several reasons. There was a study out of Uribe's group when he was at Tampa in 2012, Duke Mejian, I think, where they did an MRI and with the patient right side up or left side up. And when the patient was right side up, everything fell away just a little bit more. And that always stuck with me. Now I'm just used to it. But another thing is, if you look at an axial MRI at L4-5, the right iliac vein is a little bit further back uh, in the corridor than the left iliac vein. And so my thought is, if I'm going to hit the vein with a cob or a box cutter or something, I want it to be on the upside where I can easily control it, rather than hitting it on the contralateral side if I was coming from the left psoas. And so in the couple of cases that I've had, one was an ACR case, one was just a slip up where I slipped off the front of the spine with my suction, welling up, filling up the retractor. Again, Taco, gentle tamponade with a sponge stick, wait, talk to people in the room, make sure everybody's okay. And those patients did fine. So a benefit of having the patient right side up. But I think the most important thing is just don't panic. Gentle tamponade fixes just about everything.
Awesome, great tips. And the other ugly thing that could happen in these surgeries is the femoral palsy, right?
Yeah.
So how you monitor these patients? You use a neurophysiology in the room, or you use some brand or whatever?
Sure. You're right. So that's the other complication, ugly complication that can happen. And so when I'm consenting my patients for L4 to S1 XLIF ALIF screws, I say there's 2 scary things that could happen. One of them, you could bleed to death, which, from an iliac injury, and which isn't going to happen. And then number 2, you could have a serious nerve injury, quad palsy, femoral nerve injury. And so thankfully, I'm knocking on wood, I haven't seen that complication in such a long time. I almost forget to consent for it. I think if you're committed to an efficient technique, not rushing, but being efficient, not spending a lot of time in the psoas muscle, the rate is just so low. But to answer your question, I do the standard old school NuVasive monitoring modalities. I use the EMG, free run EMG, and also the targeted EMG to look for the nerve as I'm dilating the plexus. That works great. That allows me to get the retractor where I want it to be safely. I think that's where just about all the injuries occur. But the other modality that I use is something called TMAP, which is transabdominal motor action potential or muscle action potential. And so basically what that is there's electrodes on kind of the epigastric area and on the back. And this electrode stimulates across the conus. And so basically what you're doing is getting a transcranial motor, an MEP, but through the conus. And it depolarizes all the nerves of the plexus. And the system can tell you if it's starting to take more energy to depolarize. And I think that gives you real-time data about the health of the plexus and the femoral nerve in particular. And so, for example, if you start to see increased latencies, you could say, okay, something's going on. I need to make a change. You can reposition your retractor. You can make sure the blood pressure is okay, things like that. So I think between those 2 modalities, I feel super confident about the health of the nerves now. You know, I think it's becoming less and less of an issue. But I understand that's still a major concern of people who are thinking about adopting lateral surgery, because I think there's still a lot of kind of misinformation out there about the safety, particularly at L4-5.
Yeah. Do you have any
What do you
experience with
what do you think? What do you think? I mean, do you still worry about that as much as you used to?
I'm not in the early stage of my learning curve, but I'm still using neuromonitoring. I do a lot of ATP, so I
Yeah.
try to use less and less because it's an issue with the authorizations and the having a neurologist in the room.
Yeah.
But I prefer to have it specifically for L4-5. I think that that's the big risk, and I try to have it. I have some concerns about Safinus. You have some Safinus monitoring. There's a
I
lot of
don't.
evidence now
Yeah,
about, but I don't have any experience. Do you have?
I don't have experience with it yet. What's yeah? Tell me about the premise there. What's the proposed benefit of that?
They're supposed to be more reliable. The less false positives. Uh, I mean, that's what I read, but I don't have any experience. So I wanna collect data from the people that is using this to
Yeah,
see its value there. So
Is Ashgar doing that?
no, it does run free run and team up too.
Gotcha.
So we're in time. Thank you, Alex. That was phenomenal. I learned a lot today. Um, you were very kind for spending an hour talking with us. You're
Oh
free to
man, I'm
go,
psyched to do it.
or you're gonna get divorced. Thank you again. That was amazing, man. You made it.
Awesome, guys. Yeah, if anybody has any questions or anything, you guys, let me see. I can just this is my number. I'll put my number in the chat here, so you guys can send me a message on WhatsApp if you want to. Happy to answer any questions. Yeah, that's the right number.
Thanks, man.
Good. All right, guys.
I appreciate it, man.
Have a good night.
Be in touch. Bye.